Ladies and gentlemen, thank you very much for this opportunity to introduce you this presentation. This is my disclosure. So I have stated several peak equations in the setting of the treatment of COVID patients with anticoagulation and the prediction of VTE in such a population. And to answer this question, I am performing an ongoing non-systematic review of randomized and observational trials focused on this problem. And the first question is what VTE predictive models are validated in COVID-19 patients? And the first one is a Caprini score, which was shown to be highly correlated with the incidence of VT events in COVID patients admitted to the hospital, and that they were followed up for the 6 months, and the score of 11 and more at admission and 7 and more at discharge was strongly associated with a higher risk of VT development. In another trial, the improved D score was assessed, and there was also a good correlation, and those who had a score of 4 and higher, so they were classified as having a high risk for VTE. They have the higher rate of the development of VTE. In another paper, these two scores were compared with each other in the settings of the development of venous thromboembolism and death in COVID patients, and both of them showed a good correlation. The patients who were stratified as having a high risk according to the improved DD or the Caprini score, they also had the increased number of VT events and the increased risk of deaths in the COVID settings. Another question is, do increased doses of anticoagulants beneficial in hospitalized COVID-19 patients with a critical illness? And here we have the results of the Inspiration trial, which randomized critically ill patients to intermediate or prophylactic doses of enoxaparin. And the primary outcome was a combination of venous thrombosis, arterial thrombosis, ECMO, and death. And there was no any difference in this outcome, as well as there was no any difference in the mortality rate, VTE rate, and the major bleeding and clinically relevant non-major bleeding were numerically higher in those who received the increased doses of anticoagulation, but these differences were not statistically significant. Then another well-known trial, it's a REMAP cap active for one and attack trial combined on the one platform. It analyzed the efficacy of therapeutic compared to prophylactic anticoagulation in critical ill patients who required the organic support, and the primary outcome was organ support free days, which did not significantly different between these two groups. So there also was no any effect on the survival or death in the hospital in those who received the therapeutic anticoagulation. The major thrombotic events were less common for those on therapeutic anticoagulation. However, this outcome was not assessed separately, and it was assessed only in combination with death, and there was no any difference between the groups. The another question, do increased doses of anticoagulants beneficial in hospitalized COVID-19 patients with non-critical illness? And here we have several trials. The first one, it is another part of this triple trial, and here the patients stable without the need for organ support were randomized to receive therapeutic or prophylactic anticoagulation, and the primary outcome was again the organ support 3 days, and it was not different between the groups. Most of the patients did not require any organ support within the 21 days of observation. That's why the authors decided to calculate the proportion of patients who did not require the organ support during the observation period, and it was a little bit higher in those who received the therapeutic anticoagulation. And this difference was statistically significant but low. It was only 4%. Also, there was no any difference in the secondary outcomes like survival or death of these patients. The only difference was observed for the survival without organ support at 28 days of observation. The major thrombotic events was less common for those who received therapeutic anticoagulation, but again, they were not assessed separately, but in combination with the deaths in the hospital, there was a statistically significant difference in favor of therapeutic anticoagulation. Major bleeding were more common for the therapeutic anticoagulation, but the difference was not statistically significant. The another trial, rapid trial, randomized those who had a COVID and elevated D-dimer to the therapeutic and prophylactic anticoagulation. The primary endpoint combined the admission to intensive care unit, non-invasive, invasive ventilation, and death was not different in both groups, but however, the separately assessment of deaths showed the favor of therapeutic anticoagulation without any difference in the other components of the primary endpoint. The VT events were less common for the therapeutic anticoagulation, and there was no any increase in the risk of bleeding. The ACTION trial randomized patients who also had the elevated D-dimer to receive therapeutic rivaroxaban for 30 days or standard prophylactic anticoagulation during the in-hospital period of treatment. And the author used the hierarchical analysis, time to death, duration of hospitalization, duration of supplemental oxygen within the 30 days of observation, and used the win ratio model to find the differences. And however, there was no any benefits of the therapeutic rivaroxaban compared to prophylactic anticoagulation in these groups according to the combined primary outcome or according to the components, according to the death, hospitalization, or the need for the oxygen supplementation. However, in the group of the rivaroxaban, the risk of bleeding was higher. It was a significant increase in the risk of the clinically relevant non-major bleeding and any bleeding event. So the next question is, does extended anticoagulation beneficial in COVID-19 patients after discharge? And have a preliminary data from the COVID-19 trial, which included a lot of patients and assess the outcomes within the 90 days of observation, and was a rather high incidence of the venous thromboembolism, arterial thromboembolism, and all-cause mortality. And those who had improved DD score of 4 and higher, they were at increased risk of development of such complications. However, the extended anticoagulation after discharge was associated with a lower incidence of such complications. And the recently reported Michelle trial, which included patients who were discharged from the hospital and had the improved DD score of 4 and more, or from 2 to 3 with increased D-dimer, and they were randomized to receive the prophylactic rivaroxaban after discharge for 35 days or no prophylactic rivaroxaban. And in these settings, the primary outcome that combined the symptomatic and asymptomatic VTE, arterial thrombosis, and all-cause mortality was lower in those who received the prophylactic rivaroxaban after discharge. However, most of these events were represented by the asymptomatic DVTP that were revealed by the doppler ultrasound and CTPA. The last question is, does anticoagulation beneficial in COVID-19 outpatients? And here we have no data from the recently stopped Active 4B trial, which compared the therapeutic prophylactic doses of apixaban and ASA with placebo. But however, according to the announcement of the results of this trial, there was no any benefits of such anticoagulation in patients with a mild COVID-19 and without other additional risk factors for venous thromboembolism. But in another subpopulation of patients who were at higher risk of the development of complication, the use of sulodexide for 21 days in the outpatient facilities allowed to reduce the need of hospitalization significantly compared to those who did not use sulodexide. And also it was the influence on the duration of oxygen supplementation and the level of the D-dimer. So the sulodexide was beneficial in such patients who were treated as outpatients and had some additional risk factors for the development of complications. So, ladies and gentlemen, I would like to conclude that the Caprini score and improved DD score is validated for the VTE risk assessment in COVID patients, that there is no any benefits of increased doses of anticoagulants in patients with critical illness. There may be some little benefits in those who have this stable disease, and the extended pharmacological prophylaxis may be beneficial in those who are at higher risk of the development of VTE, and no benefits of the using of oral anticoagulation in the outpatient settings for today was demonstrated, but however, sulodexide may be beneficial in some patients at higher risk. Thank you very much for your attention.